Welcome back to PedsCrit. I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
Yes. And we are back with Palen Mallory, pediatric intensivist at Duke University, talking about APRV. Palen, we just gave you a case with a 17-year-old with primary hypoxemic respiratory failure, ARDS, secondary to a pneumonia. We've intubated her, she's on high settings, and we're considering the transition to APRV. So if this patient was being managed on SIMV pressure control, 30/16 with a rate of 28 and an FiO2 as high as 0.9, where would you start on her APRV settings?
Okay, so this seems like a good time to talk about the two primary methodologies behind how to set APRV. It's important to remember that there's no current consensus on how to set the ventilator in APRV mode, and what we know is based on small studies, maybe some animal models, but there's been no randomized trial to really test what is the best way to set APRV. So the primary numbers or parameters that we're going to set are your P high, your P low, your T high, and your T low. So your P high is, of course, the high CPAP pressure, and the T high is the amount of time you spend at that high CPAP pressure in between the drops. And those are going to be your primary determinants of your mean airway pressure. And then you have your P low, which is the low pressure that you drop to during your T low. And your T low is that time that you allow for airflow to occur out before you reinflate the lung. Those are going to be the primary determinants of your end expiratory pressure. And you really need to pay close attention to those, like I've been talking about, to avoid lung collapse and derecruitment during that release phase. And so to augment CO2 removal, you can shorten that T high and create more releases that will be at the expense of your mean airway pressure. So your T high is typically set to allow maybe 8 or so of these releases per minute. So perhaps around 4 to 5 seconds, give or take. Mm-hmm. There are 2 ways or methods that you can follow to set APRV. So one is called fixed settings or fixed APRV. And in fixed APRV, you have a constant and fixed and longer time low. So maybe 0.4 to 0.8 to even 1 second. So that's considered a longer T low. And then your P low is set at some non-zero number, usually between 1 and 5. Your T high is set around maybe 4 to 8 seconds, like we had talked about. And then your P high is typically set, you can take into consideration what your peak inspiratory pressure is on conventional ventilation. But if you have the ability to measure a plateau pressure, the typical recommendation is to measure a plateau pressure and set your P high somewhere around that, maybe slightly higher, not to exceed, 30 to 35. In your fixed setting APRV, you set those numbers, like I was saying, and you just assess how that affects your oxygenation and ventilation. And then you can make adjustments, go up on your pressure high if you want more mean airway pressure. You can go down on your T high if you want more of those drops. And you hope that your T low and your P low are set so that you do maintain some lung recruitment during those release phases. That's primarily going to be determined by your P low. Then there's this method called time-controlled adaptive ventilation. Another term for it might be personalized APRV. And this was described by a critical care doctor named Dr. Habashi in the early 2000s. And the focus in this method of setting is that your T low period is going to be even shorter than the T low in the fixed APRV setting. So maybe more like 0.2 to 0.4 seconds. And your T low is actually going to be a variable number, and it's going to be set to terminate when the ratio of your end expiratory flow to your peak expiratory flow rate has reached 75%. So that ratio is 75%. And so this uses an assessment of the slope of the expiratory flow curve, and that's going to change based on your lung elastance and recoil and driving pressure differentials and resistance. And the T low will shut off when your expiratory flow reaches that ratio of 75%, and then you'll get your reinflation. The P low is generally set at 0, and you are going to maintain lung recruitment during those releases via the generation of auto PEEP. So in that fixed setting, you maintain your lung recruitment with your set P low. In this way of doing it, you're going to maintain your lung volume at exhalation with an auto PEEP. And that's because you're not releasing all of the air in your lungs during that release phase because of the shorter time low. There is nothing out there really comparing these two ways of setting APRV. There are some perceived advantages to doing it with this personalized way. Some believe that maintaining lung inflation using auto PEEP may have advantages over that set PEEP and that it improves the air distribution throughout the lung. But there's also a con argument to that auto PEEP levels can be harder to measure, can be a little bit more variable, and a little bit more difficult to control and monitor. So those are the two ways you can set APRV. I think the commonality between them is that you determine your high CPAP pressure, looking at your plateau pressure and considering what your peak inspiratory pressure is on the conventional ventilator. And you're going to set it somewhere around that plateau pressure, maybe slightly higher. But again, not exceeding 30 to 35.
Oh, yeah.
I think that's excellent. I really appreciate you detailing both of those strategies. To reinforce the differences, it seems like the differences really come down to in the fixed setting, you're actually giving that patient some PEEP during exhalation, but that time is a little bit longer. So perhaps they're not going to exhale quite as fast, and you're going to give them a little bit of pressure on the back end so they don't de-recruit all the way. And in that time-controlled TCAV method, it's going to be a very, very short exhalation time, but there's going to be zero pressure. So you're relying on that patient's auto PEEP to maintain lung recruitment.
Yeah, and the expiratory airflow may be a bit faster in that using that method because you're going to have a higher differential, you know, between your peak and your low pressures, but it's going to cut it off when it reaches a certain ratio to prevent full deflation of the lung.
Yeah. And then, Zach, I would say that whether your P low is 0 or 5, you know, in the fixed setting APRV, an important piece of this is you're looking at the ventilator and you're making sure that you're not giving the patient a T low such that they exhale completely. So you're still looking at the flow loops and trying to cut it off at 50 to 75%. And then as the program gets more familiar, it's not just the PICU fellow, PICU attending, but also the respiratory therapist and the nurses kind of looking and being like, I think we need to shorten this T low.
Do you look at it the same way? Do you look at tidal volumes the same way? So-called release volumes? Do you try to make sure you're not getting more than 8 per kilo of a release volume, or not necessarily?
Yeah, I think that's an important number to look at as well. And the recommendations that are out there do recommend between 6 and 8 ml per kilo of that release volume. And so that's another thing to look at when you're adjusting settings. It might help you determine your P high and your T low.
All right. So to bring it back to our case, we've got our 17-year-old now on APRV. She's on a T high of 6 seconds, a T low of 0.5 seconds, a P high of 28, and a P low of 5. It's been maybe 2-3 hours since you put her on these settings, and you're still having trouble getting the FiO2 below 80 to 90%. How are you thinking about adjusting the settings to improve her oxygenation?
So we always think about mean airway pressure as your primary determinant of oxygenation, assuming you're not overexpanded. So I think it's important to look at an X-ray and look at your lung expansion and the number of ribs you're inflated to ensure that you haven't overexpanded the lungs and affected your pulmonary blood flow in that way. Assuming you haven't, then the next most beneficial move would be to increase the P high. I can't remember what number it was at.
Oh, I gave you a P high of 28.
28. So I would probably try increasing the P high to 30. And then depending on what the CO2 is, you could even stretch out the T high a bit more. You would lose some of your releases, but if the patient is spontaneously breathing well enough, you could stretch the T high so that you would spend more time at that high pressure and increase your mean airway pressure in that way as well.
So it seems like the take-home points are to increase oxygenation. Of course, make sure you don't have a pneumothorax. Make sure you're well expanded on chest X-ray. But generally, you want to increase your mean airway pressure. And the best way to do that is either increase the P high or stretch out, prolong the time at that high pressure. That makes perfect sense to me. Say, your patient, you've rescued her hypoxia, which of course always kills patients faster than hypercapnia. You have to prioritize oxygenation. Mm-hmm. Say you've gotten the FiO2 down to 60%, but you've noticed that this aggravating respiratory acidosis is still lingering. Maybe it's in the upper 60s. Maybe the patient's having a bit more work or breathing. How would you mitigate hypercapnia? How would you adjust settings to improve ventilation?
So first, make sure they're not oversedated and that they're able to breathe spontaneously, and then they don't seem to be in discomfort, or oversedated in ways that could affect their spontaneous breathing ability. And then other ways to improve your ventilation would be to reduce that time high. So that would add more release phases, essentially like increasing your rate in conventional ventilation. Other things you could do is, depending on what your tidal volume of release is, you could try to increase that. So if your release volumes are like 5 per kilo, you could do things to try to increase that volume. So you could go up on your P high, increase that volume. You could also potentially go down on your P low or stretch your T low out. Again, though, if you start manipulating those things, you really have to be careful about your expiratory lung volumes to make sure that you're not losing ground and creating atelectasis and losing your lung recruitment during that.
Something we haven't even explored yet is there any role at all for a small pressure support to be used in addition to your P high and P low to help with ventilation?
So some will use pressure support, and that has been reported in the literature to help support those spontaneous breaths and theoretically overcome tube resistance. There is some thought that adding pressure support to those spontaneous breaths could potentially increase the risk of ventilator-induced lung injury just because you are increasing your transpulmonary pressures to an even greater degree. And so a lot of centers that use APRV will not add pressure support to those spontaneous breaths. But it is a potential strategy that could be used.
Oh, yeah. Like 5 or something, right? Like a small pressure support. Nice. Now, we've mentioned this in a couple different ways, but as we sort of scooch our settings up in this patient, okay, we're going from 28 on the P high to 30, maybe 32, 34. What do you start to really think of the maximum settings? When would you say, okay, Alice, if you're my fellow, we stop it, we need to call for ECMO?
Yeah. So I think the primary thing I'm thinking about when I think that we are on max APRV support is, what is that P high? Mm-hmm. Once you start getting into the 30s, I do get concerned about the risk of barotrauma, similar to how one might think of a max setting on the oscillator, mean airway pressure in the 30s, probably. That would probably be my limit, mid 30s of the P high.
Nice. We've also mentioned this a little bit, but when you're making your plan on rounds for your APRV patient and you're starting to talk about airway clearance, how do you manage airway clearance on APRV? Are you doing the same sort of nebs, open suction? And then you expect it to be better or you expect it to be worse?
So you can definitely maintain the same airway clearance regimen on APRV that you would in conventional SIMV ventilation. Like I had mentioned earlier, there's actually some evidence that APRV use may actually enhance the ability to perform airway clearance, probably related to the increased wakefulness and spontaneous breathing, and that high expiratory flow rate that occurs during those release phases helps to clear mucus out of the airways. And this has been associated with lower incidence of ventilator-associated pneumonia.
Oh, so that's wonderful. So slow inspiratory, fast expiratory, we can all kind of picture the secretions moving well with that. Mm-hmm. Now, one thing that's different about APRV than the oscillator or percussive ventilation is that you lose your end tidal CO2 with the oscillator or percussive ventilation. And APRV is nice because you can still walk into your patient's room and see a couple narrow end tidal CO2 spikes on the monitor. Are you trusting the value? Are you wanting frequent gases for the CO2?
I would generally trust that value. Mm-hmm. I'm going to be checking frequent gases on the patient anyway. Often when there's a high degree of VQ mismatching in ARDS, the end tidal may not be the most reliable number just at baseline, mm-hmm. but I certainly would take that number into consideration as one data point of many that I have to assess, am I adequately ventilating the patient?
Commonly in patients with severe ARDS, there might be a 20 or 30 point difference in the PaCO2 compared to the end-tidal CO2. Something that I would hope for if I transition a patient over to APRV is that as we recruited more lung, our VQ matching would improve. And I would hope that the difference in those two numbers would narrow. Instead of being a gap of 30, maybe it's a gap of 20. And I wonder if I was looking over a course of 12 to 24 hours, and if my VQ mismatch was worsening and the gap between the end-tidal CO2 and the PaCO2 was widening, I feel like that would tell me I'm doing the wrong thing for the patient. I need to change something up.
Mm-hmm. Yeah, one of the perceived benefits of APRV is that it's thought that the spontaneous breathing component really helps to redistribute lung volume to those dependent portions of the lung where the perfusion is higher, and so should help with your VQ mismatching that occurs in lung injury. So ideally, yes, you would see that number narrow. Now, if it was widening, I don't know if I would take that as the sole consideration into whether I'm doing the right thing or not, but certainly one of many data points to consider.
Fair.
Now, as we manage any ARDS patient, each physician has their own way of embracing the adjunct therapies, proning, nitric, steroids. How do you think about proning patients on APRV?
APRV can definitely be used in conjunction with proning. In fact, a couple of the adult studies that I had mentioned in that meta-analysis that was done did use a proning protocol for certain patients in addition to APRV, and they commented on the fact that they almost worked synergistically in improving oxygenation in those patients. So definitely proning can be used in patients who are ventilated with APRV.
Nice. Perfect. So thinking back on our case, we got her re-recruited using APRV. Several days have now gone by. Our oxygenation is improving with FiO2 down to 50%. Respiratory acidosis is also improving now with normal CO2s. Now, in this patient's care, we're now thinking about the weaning phase of APRV. Tell us, what is the general strategy for how we reduce settings for patients on this mode?
Yeah, so the general strategy is a drop and stretch strategy. There is nothing out there, no protocol out there that says how quickly to go, how much to stretch, how much to drop. You just kind of have to use your own clinical judgment based on your experience, or if your center has a specific protocol that they've created. But the idea is, as your oxygenation and ventilation improve, you can start to drop your P high, just as you would drop the mean airway pressure on the oscillator, or start dropping your PEEP on the conventional ventilator. And then you can start to stretch out the time high so that there are fewer releases per minute, and that the patient ends up their lungs are better. So hopefully your CO2 clearance is improved just because of that. But then their spontaneous breathing will really start to take over the majority of the CO2 clearance as you stretch that T high even further. So eventually, you could think about basically getting to a constant CPAP level, and you can actually extubate from APRV. You don't need to transition back to conventional ventilation. Some might transition just mostly out of comfort, but you certainly don't need to. You can extubate straight from APRV on a CPAP level.
Oh, well, that's wonderful. That's a very aspirational move I feel. I've been taught to wean the P high nice and slow, like the way a lot of intensivists do a PEEP wean, just like less than 2 at a time, less than twice a day. Is that your mental model as well?
Yeah. Yep.
And of course, we're really dependent on the pathophysiology causing the lung disease, like bad ARDS and pneumonia. We know that's going to get better slowly, so that doesn't necessarily get better overnight. But maybe like if it was primary atelectasis and you got them re-recruited and reversed the cause of causing their atelectasis, you could maybe be a bit faster. But
yeah, it's
definitely
like
defer to you guys for that.
No. Zach, it's like I could hear you roasting me at sign out. Like, come on. Yeah. So we've talked a lot about the potential benefits of APRV and how much literature there is. And then we also have this, or at least what I perceive to be a trend in the field, where we have ICU outcomes researchers and ICU delirium and sedation researchers really shrinking the amount of sedation that we give to the patients, and early mobilization and minimizing paralysis on one side of PICU research right now. And then on the other side of ARDS research, we have maybe a benefit of 24 hours of paralysis early. We've got prospect that involves some early paralysis. I wonder if APRV is a way to optimize lung recruitment with minimizing sedation. And I'm wondering what you think about where we are now in pediatric use of APRV and where the field is going. Do you think we'll ever get a prospect level randomization for this mode of ventilation?
Best case scenario, we would get a prospect level randomized controlled trial. I think that's the only way to really answer this question. We can keep doing small single center randomized trials or retrospective studies, multi-center retrospective studies. But I think before that happens, we really need a consensus on how to set it and when to start it. One of the big questions that no one has answered, particularly in pediatrics, but in adults as well, is should this ventilator mode be considered as a primary ventilator mode as opposed to a rescue mode, which it traditionally is thought of being? And before we did some sort of study looking at that or looking at its use in ARDS, we really need to know what is the best way to set it. Is that fixed APRV strategy the most effective? Is the personalized strategy the most effective? And to perform a randomized controlled trial, we need everyone doing the same thing. And we need a high number of patients. So it needs to be multi-center, but we need everyone to be doing the same thing. Just like Prospect has a very regimented ventilation protocol so that everyone is doing the same thing, we would need that for APRV. But it's hard to create that if we don't know what the right thing is. And so I think that needs to be evaluated and studied first before any large randomized controlled trial in pediatrics were to occur. I think its role as a resource in areas that don't have ECMO as a rescue mode is really interesting. And I think that should be considered and maybe looked at more. Mm-hmm. Another area that's really interesting is use of APRV during ECMO as resting lung settings. There is maybe some traction toward increasing use of APRV and studying APRV during VV ECMO right now, but nothing out there is really definitively saying it's helpful or not. But I did use APRV as rest settings occasionally in my PICU fellowship. So I think those are areas of great interest that could be studied in adults and pediatrics. I think a lot needs to be determined before we could have the ability to really successfully perform a randomized controlled trial in kids. I think it would be great, but we need to figure some of the other details out first.
Mm-hmm. Yeah. It's been a real pleasure talking to you today about APRV. I want to commend you for taking on this challenging topic. We talked about how a major barrier here is a lack of familiarity, across centers with this setting. So we couldn't assume much knowledge. And I did, being self-disgracing is probably one of the best parts of being on this podcast. I don't know very much about APRV, so I feel like I tried to take on that role of asking all the questions that don't have as much clinical context. But I do think our conversation today will increase familiarity with what is APRV, how to get started, and being aware of some of the pearls and the pitfalls. As we wrap up today's conversation, anything else you'd like to mention or plug for our listeners?
No, I think that APRV should just be thought of as another potential mode of ventilation with potential indications and contraindications, benefits and risks, all of those. The user needs to be aware of those things, and all of those require further investigation, of course, but certainly as a potential rescue mode in someone who is not an ECMO candidate or in a place where you don't have an oscillator, APRV, I think, certainly deserves consideration in the right patient. So patients with ARDS, patients who are able to spontaneously breathe. I think that's the role that APRV has in pediatric critical care right now, and certainly deserves further study in the future.
Oh, well, Dr. Palen Mallory, thank you so much for joining us today.
Thank you for having me.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.